The Steward Health Care system has been in the news for virtually the entire year of 2024. Its bankruptcy has shaken up the healthcare environment in Massachusetts. Hospitals have closed, access has changed, billions of dollars in debt has been revealed, and many people are asking questions. This is something which is actively being pursued at the time of this talk, but I wanted to take some time to explain things and provide some perspective so that people watching this presentation will know more than just what they're getting from the standard media and will better understand the solutions that are being proposed. What I'm not going to do is spend a lot of time going over this very complicated organizational chart, but it does emphasize the fact that this is an extremely complicated Byzantine organization. Worth noting is that when Steward Health Care started by purchasing the Caritas healthcare system in Boston, it was just where that black circle is. It was a very small organization. They underwent observation by the Attorney General's office and were very limited in their activities up until 2015 from the start of the organization in 2010. So during that period, not a lot happened. But once the observation and restrictions of the Attorney General were lifted, what we see is the growth of this chart, which happened in just a couple of years as they underwent rather explosive growth. So in talking about this, what I want to do is give you some perspective about the hospital environment to begin with, and we'll go a little bit with history here and take you through a couple of generations of hospital evolution in the country and in Massachusetts. And what we see here are two pictures of two hospitals in Massachusetts 100 years ago. Henry Heywood Hospital in Gardner is on top around 1920, very modest institution. Underneath is Massachusetts General Hospital, our oldest hospital in the state. And again, a nice institution, fairly modest by today's standards. Hospitals, as they began, were charitable organizations. They were to deliver health care to the poor. And they dealt with volunteers, they had contributions, bills were paid based on the fact that they were able to raise funds, and that is how it ran. As medicine advanced, as more could be done in the hospital, patients who were able to pay were coming to the hospitals because the level of services was becoming too sophisticated to be delivered in their home. So that's how it started. And then in the 1960s and 1964, with Medicare for the elderly and with Medicaid for the poor, hospitals were offered federal payment and state payment for a population of their patients who previously had largely been charitable. So they welcomed this funding because it was dollars where there weren't dollars before. But that is where that is the part of their market, the part of their patient population that was taken up by these two new services. But still, with the advent of all this new money, expansion occurred. Patients stayed longer. More patients were coming to the hospital than otherwise would come. And so hospitals underwent an expansion, particularly in the 70s. But then in the 1980s, contraction occurred. There were a number of reasons for this. Stays were shorter. Operations that required a big incision then needed a small incision. Some things that were done as inpatient are now done as outpatients. And so the hospitals were put under some stress that they hadn't been under before. Add to this the fact that the payment methods by Medicare and Medicaid were starting to break budgets. And the federal government started looking very carefully at what they were paying and trying to figure out a way of getting this under control. Up until then, basically the hospital would assign a fee to a procedure. They would send a bill to the insurer, to the patient, and they'd get paid their fee. In trying to bring this under control, the federal government started using something called diagnosis-related groups. The bottom line is they were going to say, if you're coming in for a gallbladder, here's what we're going to pay you for a gallbladder. There it is. You've set a fee. To try to adjust for the fact that patients were different, some were sicker than others, They started adding certain modifiers to these formulas. The hospitals responded by hiring consultants to figure out ways to get more modifiers onto their bills. And in the long run, it did not bring the costs under control. But nonetheless, a key idea here is that Medicare and Medicaid were really paying below what the hospitals felt were their basic costs. And so the hospitals were in a position, in addition to collecting money from Medicare and Medicaid, of trying to shift some of the expenses over to private pay. And so that is key to understanding what is going on here, because basically we had situations like that arising with cost shifting occurring. In addition to that, it's important to know that the private insurers were negotiating one contract at a time, one hospital at a time, so that what one insurer was paying one hospital was not necessarily the same as what the other insurers were paying that hospital, and was also a different fee from what that same insurer was paying other hospitals. All kinds of bargaining going on here, which is just a recipe for problems. So what has happened? Well, during that time, the number of beds in this state, the number of hospitals in the state has cut down over the span from between the 70s and the 2000s by 50%. There are 50% fewer hospitals, 50% fewer beds. This is a industry that is under some stress. Hospitals responded to this by reasoning that if they own the doctors' practices, that they controlled the referrals by those doctors. So they launched into the line of work of buying medical practices, of hiring doctors to work for them, to try to ensure the referral source. This was initially billed as vertical integration, a more integrated service provision. It was felt that it could improve quality, it could improve cost control. It's really debatable as to whether it did either of those, but there's one thing that nobody debates about this, and that is that it definitely increased the bargaining power of the hospitals. The bigger they were, the more prestigious they were, the more likely they were to be in a favorable bargaining position. And hospitals began merging with each other. So we know Mass General and Brigham merged into partners in the early 90s. And in addition, UMass Memorial and Worcester underwent a series of mergers, so that at this point it controls almost all of the hospitals in Central or in Worcester County. And Caritas Christi enters into this equation as well. The Diocese of Boston had a number of charitable hospitals that were providing a service to the poor and were not-for-profit institutions. They were struggling, and so like everybody else, they decided maybe a merger was a good idea. So in 1985, the 6 diocesan hospitals came together as the Caritas Christi Health Care system to increase their bargaining power, to centralize some of their low-volume services, to consolidate some of their administrative work. So it, on paper, was a good idea, and it was intended to help them to survive in this very competitive environment that they were in. And from 1985 to 10, 15 years beyond that, it did serve them well. But the problem is that we have these payers, Medicare and Medicaid, who are under cost, private payers who are having costs shifted to them, and the private payers negotiating based on the necessity of having a contract with that hospital. If you undergo a period of recession, your mix of private and government payers may change, and that is something which could be critical. So that by 2005, Caritas Christi was in financial trouble. They had run up debts. They had not been making payments for their pension program. The board was meeting overtime. They were getting consultants in, and the consultants basically advised that they should distance themselves a little bit from the diocese. They should run on a more business-like way. They needed new leadership, and they undertook a search to see who could bring new ideas to them. And into this comes Dr. Delatorre, And Ralph Delatorre actually has a really remarkable history. He is the child of Cuban immigrants. His father was a physician. He graduated with a degree in engineering from Duke. He then went on to go to Harvard Medical School and MIT. Graduating from there, he went over to Massachusetts General Hospital, where he trained as a cardiac surgeon, and eventually found his way to Tufts Medical Center, where he had a very prosperous cardiac surgery practice. During this time, he gets interested in the business of healthcare and health policy, and approaches his department chair and basically says, you know, we're both very productive. We're both very important to this department. I'm not sure that our income is really a fair recognition of the value we bring to this institution. With your permission, I can go to the administration and see if I can negotiate a better contract for the two of us. And the chair felt that that was not a bad idea. Delatorre goes off, negotiates with the administration, brings back a good raise for the two of them, and very much impresses his department chair. After a period of time, he again comes to his chair and says, you know, as a department in this hospital, we are much more productive and important than we are being recognized for. And I think we should try to separate ourselves and set up a separate institute within the organization where we have more control and better recognition for our services. And in fact, he was successful in bringing that to fruition. And as he looks around, he's looking for more. He's really got the bug, and he knows where the power is in Boston, and meets with Jack Connors, who is an executive in an ad agency, but is a mover and shaker in Boston, who is connected to almost everybody, and is chair of the board of Partners Healthcare at that time. He meets with Connors, impresses him tremendously, says Partners really isn't looking for someone at this time. However, I know who is, and let me get back to you. Connors then contacts the bishop, says, I've got this Dr. Delatorre here. I think he's just what Caritas Christi needs. The bishop responds saying, we've conducted our search, we have our finalists, and we're pretty okay. We've got 3 finalists. And Connors responds, well, now you've got 4. Well, you know how that turned out. They did interview Delatorre. They were taken over by his vision, and they did hire him to be the CEO in 2006. He works on the business plan of Caritas Christi. He makes the books look a little bit better, but I think there's a general sense that they aren't going to be able to pull it off. And the reality is that their credit rating at this point is so poor they really can't go further into debt. They look around to see if they can merge with other Catholic networks that are national networks. They get looked at by these organizations who say, no, thank you, we're not interested. They look at for-profit, publicly traded organizations in healthcare, such as Tenet Healthcare. And again, Tenet says not interested. Other not-for-profits say not interested. And at that point, he meets with the CEO of Cerberus Capital, a private equity firm having nothing to do with healthcare. He flies to California, has an 8-hour meeting with their CEO, and impresses him enough so that he comes away interested in investing in Caritas Christi. Now, worth knowing that Cerberus at this point is not in healthcare at all. They have no particular expertise in the field. It's also 2009 or so, and we're in the middle of a significant recession. Cerberus had just gotten over a bankruptcy. They had been owners of Chrysler Motors, and that was driven into bankruptcy. And they were looking for other areas to invest in. Obamacare is coming online, and people with money are thinking that once everyone is required to have health insurance, that it would be a good idea to get into the health industry some way. There was money in there to be made. And so this appealed to Cerberus at this point for a number of reasons, those being among some of them. Now, unknown perhaps to Cerberus was the fact that Obamacare was based on what was going on in Massachusetts for a few years at that point. So whatever bang there was going to be to the healthcare industry, it kind of happened here already. But nonetheless, they were interested. They were making a proposal and were actively going to bid on getting into this healthcare system with Caritas Christi. So I'm going to give you a timeline here, and I'm really going to simplify things, but I want you to get the big picture. And so in 2010, Cerberus comes in, and the way the system had been evaluated was that they said we owe somewhere in the ballpark of $300 million for the pension plan. There's roughly $300 million or so in debt that the system has, and there are capital improvements in the order of 400 million or so that need to be made. And so the price tag on all of this came up to roughly $900 million. And that was what people were looking for. That was what the consultant said was a fair price. Interestingly, if you were to look in these consultant reports and search for words like building or real estate or the like, they weren't in there. The system was being valued based on how much money it owed and how much it needed to clean up their fiscal plan. So that is what they came in with as a proposal. And because this would be moving a not-for-profit into a for-profit, the Attorney General at that time, Martha Coakley, became involved. She had to approve this for it to go forward. They conducted a significant review of everything that had been done, all the numbers that were there, and received testimony from the public. There was no shortage of testimony expressing concern regarding this private equity possibly depleting assets, raising prices, cutting services. All those things were expressed by people who had very strong feelings. Nonetheless, instead of giving the standard 3-year period of oversight, Coakley expanded it to 5 in a concession to all of these complaints that she was hearing or concerns that she was hearing. Interestingly, though, in her report, terms are exchanged a little bit. And so one wonders what they were thinking at that time, because in some instances, they talk about assuming debt. In other instances, they talk about paying the debt off. And in fact, what is in Coakley's report is this quote: assuming debt and pension liability are paid with the purchase, the financial viability of Steward is going to be much better. They are going to have lower expenses because they will be essentially debt-free. So there, as I say, the critical difference between payoff and assumed debt are critical here, because in fact what happened was that this $900 million proposal was financed by roughly $250 million from Cerberus, and the rest was debt that was essentially continued or put on the Steward Health Care system. And Cerberus, creating Steward Health Care with Dr. Delatorre as the leadership of that organization, had backed itself away from any sort of liability that Steward may have incurred, and that was the position going forward. So this is what happens in 2010. In 2015, after the 5-year observation period, the Attorney General again reviews them, this time Maura Healey, and she is very aware of the concerns that were expressed in the earlier report. She has her checklist. They didn't move out of state with their leadership. They didn't pay themselves a dividend while they were in debt. They kept the hospitals open. And so she says, based on these criteria, she can release them from the oversight of the Attorney General's office. However, at this time, she also knew some other things, which is in the interim, they had purchased Quincy Hospital and another hospital. Quincy was in deep financial trouble when they purchased them, but got even more into financial trouble. And even though they had promised to keep Quincy open for approximately 10 years, 2 years after they purchased Quincy, they shut it down. And even though the regulations would specify a number of months before you actually closed the doors in a situation where you announced a closure, they closed it in a matter of weeks. The Attorney General did not press this issue. They negotiated that they would keep a emergency room open for 8 to 10 years, but that was about the length of it. But she was aware of this. She was also aware of the fact that there was some financial reporting that was necessary on the part of Steward, and there were concerns regarding the completeness and accuracy of these reports. Fines were being imposed on Steward, and Steward was responding to this by saying this isn't fair and litigating it. So it hadn't been settled yet at that point. So those were the kinds of things that were in the background, in addition to going right down the checklist. But nonetheless, she approached it with an air of optimism. She responds to the people who in 2010 had raised concerns and says, 5 years later, the most dire of these concerns have not come to pass. Steward has kept the former Caritas system intact and operated the system as it had proposed. However, during this time, their operating losses had increased. The pension plans were under more stress than they had been at the beginning, and the total liability had increased by a significant number of dollars from when they had first obtained the contracting. So it's important to know all of that. So 2016-17, so less than a year goes by from the release of the oversight by the Attorney General, and Steward basically sells the property that they have with these buildings to an organization, a real estate investment trust called Medical Properties Trust. So they basically give themselves a bolt of money, $1.2 billion, by selling the property and entering into lease arrangements with this organization. So that they're getting a bolus of money, but they've increased their overhead because now they have to pay rent for buildings that they previously had owned. They use the same pattern and go on a shopping spree. And basically they go from having roughly 8 hospitals in 2015 to 35 hospitals by the 16-17 period of time. And they closed one, Quincy Hospital. However, they've gotten really big. And the pattern has been there exactly the same as what they did with the original Caritas. So what they did was they would buy a hospital, sell it to Medical Properties Trust, get a bolus of money, and then buy another hospital, Medical Properties Trust, bolus of money, and move along the line, expanding themselves by doing this. And into this, by that time, Medical Properties Trust has invested more than $4 billion into this system. And Cerberus takes a dividend of $484 million. The debts are not getting paid. And now there are bills regarding rent on all of these buildings as well. If we move up to 2020, a number of things are going on. First of all, we've got COVID. And this is stressing hospitals in 2 ways. On the one hand, the routine care has decreased, and a lot of cash flow for the hospitals has gone away. By the same token, their intensive care units, with all of these sick COVID-19 patients, are in overflow condition. The government has responded by providing a number of grants and rescue funds to try to keep these facilities open. And the Mass Nurses Association reports that a intensive care unit that Caritas was reporting was open was in fact closed. The Department of Public Health responded by asking Steward, is it still open? And they said, yeah, it's open. The nurses responded to that by taking a picture of the closed intensive care unit and sending it to the Department of Public Health. The Department of Public Health did not respond to this. The Mass Nurses Association is also starting to record numerous violations and concerns regarding quality. A hospital that Steward purchased in Western Pennsylvania is under financial stress, and again is critical to the healthcare response to COVID. And the Steward administration tells the state of Pennsylvania that they want $40 million to keep the hospital open. The government of Pennsylvania responds saying that they don't feel that they can afford that they feel like they're being held hostage, but they do give Steward $8 million. Within 6 months, Steward closes the hospital anyway. Cerberus is looking around, and as a private equity firm that usually gets in and out of an investment in 5 to 10 years, 10 years have gone by. No good news on the horizon here, and they feel it's a good time to try to bail out. What they need is somebody with enough money to buy their share. And the proposal is that Delatour will put together a group of doctors that can manage Steward Health Care, and they can buy out Cerberus's share. Cerberus approaches Medical Properties Trust, says, to keep this viable, we propose that you make a significant loan to these physicians. They'll buy us out. It'll keep the organization going, and it will keep your investment in this property viable. So Medical Properties Trust at this point gives $335 million to these doctors. The doctors respond by buying out Cerberus, but also giving themselves a $111 million dividend. And Steward's 40 hospitals, of which they've closed 3, are still nearly all in significant financial trouble. So that is what's happening up to 2020. In 2022, Cerberus is out of the picture. Medical Properties Trust is into this investment for numerous billions of dollars. They're not collecting their rent, and they're looking around to see what they can do to mitigate their risk. They decide that mortgaging the property that they bought would be one way to do that. That will transmit some money to them, puts them in a position where they can essentially abandon the property and leave it to the people who own the mortgage. And so they were able to induce a number of mortgage lenders to mortgage these properties and mitigate Medical Properties Trust liability here. So that is the setup. All of that to getting us into the filing. And in May of 2024, Steward declared bankruptcy using a court in Texas, in Houston, Texas. At this point, Cerberus is not involved. They have been estimated to have netted $800 million on their $250 million investment. And the total debt listed is $9.2 billion. However, the vast majority of that is future leases to Medical Properties Trust, and that really isn't money that they can expect to collect at this point, now that Steward has declared bankruptcy. In fact, Steward actually went to the court and asked that their leases with Medical Properties Trust be vacated. And so what we've got is significant debt. Vendors are owed money, staff is owed money, supplies have not been provided for basic care. Care is deteriorating, and that is where we are when the governor begins to step in. And her initial response was to infuse $30 million in what amounted to prepaying some Medicaid fees to try to keep the doors open while these negotiations occurred. In fairly short order, more money was flowing. And at one point where they're trying to secure people to buy these hospitals, the governor, or Healy now, says that she is going to take St. Elizabeth's Hospital, one of the larger hospitals in the Massachusetts system. And she's going to take it by eminent domain. And she says, I'm going to give them $4 million for it, take it or leave it. Sounded good, but I think everybody involved knew that if the government is taking something by eminent domain, they have to pay market rates. And the evaluation of St. Elizabeth's Hospital was a little over $200 million. So the $4 million remark was a little bravado, but it really wasn't a real number. And as we see this unfold, we've gone from a state commitment of $30 million to more recently $70 million, to the most recent being 700 plus over the next 3 years. to bail out this one system as it wound into this problem over the period of about 14 years. Now, let's think about this a little bit. What are the issues with private equity in healthcare? Well, one is that the expectations of private equity are much bolder than the normal publicly traded companies or bonds or other ways of investing money. The investments in private equity are essentially fairly short-term, 5 years, maybe 10, larger yields, higher risk. That's the game that is being played. Yet if we look at the hospitals, and the numbers on this graph here are from the Massachusetts hospital system as a whole, what you see are hospitals that go up and down maybe 2% a year. They may have a good year in which they're 2 or 3% ahead, and a bad year in which they are 2 or 3% below. Very often when there's a difference there in the not-for-profits, it's made up by money from the endowment, but for-profits, that endowment is not there. So they're investing and expecting really high returns in an industry in which you have very little room for profit. That's one thing. Community hospitals have less bargaining power, and they were investing in community hospitals. And so there's that issue as well. You were buying something where the ability to raise more funds by cost shifting to the privates wasn't quite the same as it would be for a large, prestigious academic institution. And hospitals with higher percentages of government payment are going to be more vulnerable to all of this chaos. And the Caritas system had a higher percentage of government payment. So basically, Cerberus was stepping into something in which the odds of their winning were not very high at all, playing by the usual rules. The only thing that would appear to be viable if their job was to extract money would be to use the property plan of selling property and then leasing it back. In addition to that, besides the high investment expectations, the short time horizon, know that a not-for-profit hospital is in the business of delivering a service and looks around for ways to get money to provide that service. The business of private equity is to make money, and they are using that service in order to make more dollars. Their philosophy is flipped on this, and so that perspective weighs into the decision-making, the timelines, and everything else. They operate through intermediaries. As I said, Cerberus was removed from Steward and the individual hospitals to escape liability. And these selling assets and leasebacks, this isn't something that they invented for the Caritas Christi system. This is standard operating procedure for private equity. It is seen throughout our economy at this point, and this sort of outcome is not unusual at all. What you see in this graphic here is a study of over 1,500 hospitals in which they looked at the net assets of hospitals year upon year. And they plotted the net assets of not-for-profits who stayed that way versus those who were taken over by private equity. And what you see here is that it is not unusual at all for private equity to move in and diminish their assets. And that's exactly what we saw happening here. It's predictable. It's the way they work. Now, the other problems have to do with the payment variation in this system. I mentioned to you the fact that Medicare and Medicaid are paying less than cost for the hospital care that is delivered. And I also mentioned to you the fact that costs are shifted to the private side, and the privates are negotiating individually with hospitals. So what you see here on this graph is the little orange ball is how much a hospital is being paid for a standard service. And if you're running a hospital, you want your orange ball to be as far over on the right as you can get it. And so you see that some hospitals that are very high profile, Mass General, Brigham and Women's, Children's, Dana-Farber, they are able to extract higher fees. And in addition to that, the blue line is of the private pay hospital dollars spent in this state. What percent are going to that hospital? And you see here that the bars are way over to the right for Mass General and Brigham and Women's. Those two hospitals in a system with 58 hospitals. Those two are getting over 25% of the dollars. They have high volume of services. They are big hospitals, but they're also getting paid a lot more per service. So that is where we are. The current system has big players doing very well compared to the smaller players that have less negotiating power, as well as a higher percentage of government pay. So yet another graph. And what I'm talking to you about problem variation here is that while they're trying to shift the private payment and make up for what they're losing on the government payment, there are differences here. And so you see that the hospitals that are doing fairly well have roughly 40% private payment. The hospitals that are not doing well, and this includes St. Elizabeth's, it's under 30%. And so that's the degree to which we are talking in this. And in addition to that, we have the reality of knowing that the cost shifting doesn't just occur between insurance companies and between hospitals, but even within a hospital itself, there is cost shifting going on with some services subsidizing others. And what we've seen over time is that certain services, such as mental health services and drug treatment services, are ones that do not raise many funds at all, have to be subsidized by surgical procedures and the like, so that internal cross-subsidy is occurring as well. And what this has led to is that hospitals have cut down on the availability of mental health services, the availability of drug treatment services. Patients who need these services are backing up in emergency rooms, and the system as a whole is clogging. So what to do? Well, standardized fees is a very tempting thought here, and this is something I want to bring up to you. So this isn't new. It has been tried in Maryland since the 1970s. They got an exemption from the federal government and had what is called an all-payer fee schedule. So they were going to get more money from Medicare, more money from Medicaid, and have a system that was a little bit more stable than what we're observing here. They avoid the one-offs, such as what we're seeing with the Steward Health Care system to try to save people who are sinking. And they preserve competition, but the competition is based on service as opposed to bargaining and pricing. And it removes the incentives to merge into these huge units that we have right now. If you look at other healthcare systems, many European systems where everyone is insured, the insurers that are there pay off of a fee schedule that is the same for each insurer. And what we see among physician practices, as an example, is primary care groups are maybe 5 doctors or less. You don't see these mega groups that have gotten together essentially as a bargaining unit. You don't see huge numbers of hospitals consolidating again into a bargaining unit. And so this alleviates a lot of the overhead and complexity of these bigger systems. And this is not a new idea. It's not my idea. If I go back 25 years and look at different quotes that are here and there, Alan Sager, who is a respected health policy person at Boston University School of Public Health, 1999, no service should cross-subsidize any other service. It destabilizes things. Not hard to figure out why. The Attorney General's office has been turning out a cost drivers in healthcare report every 1 to 2 years since 2010, and essentially beating the same drum using different words. Standardized payment in 2010, address variation in provider prices in 2015, promote equity by aligning provider prices. So the notion is there even at the Attorney General's office level. And then in Massachusetts, we have a health policy commission that was created by the same legislation that created our health coverage. And what they have said is adopt fee schedules, eliminate these payer differentials, which are driving consolidation, care inequities, and driving up costs. So the idea is out there. It's been out there for a very long time. What's keeping it in place? Why hasn't it happened already? And I think the answers are a couplefold. One is the government can't afford it right now. That was a big exception to give Maryland that program. But it's estimated that Medicare and Medicaid would have to increase their fees about 30% or so. Big amount of money. By the same token, even though hospitals feel that Medicare and Medicaid are underpaying, the fact is that Medicare is losing money, is scheduled to go broke in less than 10 years. Medicaid in every state in the union is a budget buster. And so to be able to get them to pay 30% more would really put both state and federal government under huge stress. In addition to that, there are winners and losers in this cycle. And the winners, the big systems, the Mass General Brighams, the Blue Cross Blue Shield even, have a great deal of political influence. And the system as it is working pretty well for them. There's been some talk about how we've tried it before and it didn't work. But I can tell you that the rate setting that was done back in the 80s really didn't accomplish what it was set out to do. And so I would not dismiss the idea because we tried it before. So that's it. And what are the key takeaways here? Well, what I want you to know is that cost shifting no longer serves the poor. It is fueling inequities among patients and institutions. The cost shifting idea is something we need to pay attention to. In addition, profit differentials in services have led to shortages. Differences in fees among institutions have driven shutdowns, they've driven consolidations. That has not helped our system. Shifting costs from government plans to private plans has destabilized our system. And multiple reports from various agencies have all pointed to the benefits of a fee schedule type of system. The costly bailout of Steward Health Care hospitals is necessary, but it just gives oxygen to the canary. It doesn't give any oxygen to the coal mine. So that's my perspective on this issue. I have some references for you here if you are interested. Thank you.